Welcome to the Scoliosis Dialogues, the SRS podcast. I'm Chris Hardesty. I'll be your host today. And my guest today is Dr. John Street of the University of British Columbia and current president of the Canadian Spine Society. Dr. Street is going to be leading a session at IMAST called The Great Canadian Debates and Controversies on Thursday afternoon. So welcome, Dr. Street.
Thank you, Chris. Thanks for the invitation, and we're really looking forward to being involved in the meeting.
All right. So let's start off with there's a reputation that Canadian surgeons are collaborative and, well, polite. So, what's your strategy for a debate that's both collegial but also genuinely challenging?
Yes, I think that certainly the Canadians have, we've earned the reputation of being polite, but I think we've also shown that if crossed, we can certainly have some answers. And so I think if I was coming to the debate, I'd be expecting it to be a little more like the opening of a high stakes hockey game, maybe than it is of a debate. Um, we purposefully chose pediatric spine surgeons and adult spine surgeons, so they're going to come at it from very different contexts and very different views. And then we also purposefully chose personalities who, don't like being told they're wrong. And so I think that people are coming at it very enthusiastically. And so I'm expecting it to be lively, but also very informative. I think that the lineup is clear that there's people who are expert in those fields, who are, by reputation, people will know are not afraid to share their opinions. So I think you'll see the best of the Canadian approach because I think there will be lots of evidence, but you'll also see a side that's, like I say, more akin to the hockey rink than maybe than it would be to a traditional debate.
We'll have to wait and see who's the first one to get hip checked into the boards.
And if you have a look, there's a number of them who, have played hockey, and so you can check out their teeth. That'll be pretty obvious.
Okay, I'll look for that too. Now, this session is what we call a can't miss session, and it does cover some controversial debate topics. When you were putting this particular program together, what themes or trends were you hoping to highlight for the audience?
Yeah, I think the underlying theme that we were trying to highlight was that we're past the point maybe of knowing how to do things. We've got such great technologies now with preoperative planning, robotics, intraoperative navigation, biologics. I think more it's the philosophical debate of what should we do rather than how technically can we do it. And so I think that we're expecting most people in the audience to come and based on their experience or their training, they're going to have a certain approach to this problem. And we're not aiming to teach them a technical aspect of an approach, but rather how you can have a constructive dialogue where there may be philosophical differences in how you approach it. So really that's what we're aiming to do is to highlight that we believe, I guess, that as spine surgeons, we're going to be we've reached such a level of technology and capability from a technological perspective that I think more and more the questions we'll face are more philosophical rather than technical.
We had a discussion about that just yesterday, especially since IMAST is such a meeting about changing technologies and how you thread the needle between adopting a technology early versus watching for a little while to see what other people do, and then talking to your trusted colleagues at an SRS meeting like IMAST to figure out how you want to adopt those things into your practice.
Yeah, and I mean, there's the old adage, you shouldn't be the first nor the last to adopt a new technology. Or at least if you are, you're going to have, more challenges. And we do, of course, we need the early adopters to push us. And you also need the maybe people who are more sit and wait and see how the adoption has leveled out and where technologies find their niche. So yeah, we're hoping that this debate on all three topics has that same underlying theme.
Excellent. Now, looking at the lineup of topics, which presentation are you personally most excited to hear or discuss? And is there a reason you think that topic is particularly important right now?
Yeah, so I think that no offense to the other four debaters who are not going to be shortlisted here, but I think Doctors Stefan Perron and Dr. Steve Lewis on the high-grade isthmic spondylolisthesis, because I think that, again, they're two very strong personalities with very strong opinions. Um, and they're, again, talking about that, what I believe is that kind of core topic where, one approach to an isthmic spondylolisthesis is to create the best looking X-ray. You're really proud, everybody on the team's high-fiving because you've had this great surgical result. But we know, particularly for this pathology, that that comes with significant risk. And so having somebody else come on the with the philosophy or with the approach that one has to consider more with respect to the risk and not necessarily what we can achieve from a perfect X-ray, perfect technological achievement. So I think that I'm looking forward to. And again, as I say, the pediatric people will come at it from a different lens of, looking at things like growth and looking at potential, whereas the adult surgeons more look at it as far as, down the road compensation and, you know, what's my plan C, D, E, and F? Because, from when doing adult spine surgery, you need multiple plans. And so I think that, I think the mix of the personality and the topic, I think for me, I think that'll be the highlight debate. And as I say again, I'm sure I'll get some stick from the other four debaters for picking that one, but
That's all right. And it's good that it's right in the middle. So you'll have a chance to hear all of it. Do you think there's any area in which treatment in Canada differs significantly from the way things are treated in other geographic areas? And what do you think our audience might learn from your speakers?
yeah, I think that from from a surgical technology perspective, I think in Canada we're there with everybody else. I think we're using all the newest technologies. I do think that the single payer healthcare system does create almost like a responsibility that one has to be maybe um, thoughtful about the expenditure, thoughtful about that the use of that technology. Um, because we have a limited budget. We have to, I think we spend maybe a little more time, or at least we're put into the position where we have to spend a bit more time about resource stewardship and what we should be doing and to whom. So I think that does engender some more thoughtful, I think, consideration of the case. Um, and so I think that's one thing that's uniquely Canadian about this debate. And I think we'll see that come through in all the three debates, because of course the decision making to do a big surgery is small, to do a surgery early or late or not at all. The resource implications and resource stewardship are uh, very important considerations in that decision making as well. So I think there's that, and I do think that Canadian um, publications, research, the key opinion leaders that we have in Canada in these topics, I do think that their opinions are respected, and I think that we're seen as maybe taking a very evidence-based approach. I think there's maybe a bit less dogma and a bit more of show me the data and then show me the data for 10-year follow-up. I think those are things that maybe that I think certainly our most recent Canadian Spine Society meeting, um, that very theme was very strong. Was the idea that we're trying to produce Canadian data, which we feel, being in a single payer healthcare system, removes many of the um, challenges or conflicts around certain care delivery or decision making around that. So I do think that that will be something that maybe many of the attendees won't a perspective they may not have been introduced to before.
Yeah, I feel like when I've spoken with Canadian, at least pediatric orthopedists in general, before, their treatment decisions are also sometimes affected by the length of time between the decision for surgery and the actual surgery. And that sometimes they're faced with a more complicated picture because it's taken a little longer to get to the OR. I don't know if that will play any role in.
I do think it'll play a role in the debate around the curve magnitude for correction and fusion in adolescent scoliosis, because when when one of my pediatric colleagues books a kid for scoliosis correction surgery, you're doing that anticipating the surgery won't happen for about 18 months to 2 years. And so you have to factor in the growth of that curve over that time. And so you're certainly making the decisions potentially earlier in the evolution of the curve magnitude, knowing that by the time you get to it surgically, it's going to be considerably bigger. So I do think there's some nuances in we wouldn't have to consider if we were able to offer surgery in a more timely way.
Very good. Debates can sometimes feel like theater. So how will you make sure that this is not just entertaining, but actually changes the way people think?
Yeah, I think that first of all, I think that the theater part is an appeal, because I do want people to
Right.
feel that they're coming to the debate not just to hear six short instructional course lectures and then leave without having had some uh, uh, discussion around that. Um, I want people to come and feel like they could have fun at it, that they could actually be entertained watching these people debate. Um, and also, I think I want people to feel, sorry, leave the session maybe feeling a little uncomfortable, thinking, oh, they were pretty harsh with each other, but at the same time thinking, hmm, I didn't consider that, or I hadn't thought about that before, or that's a way of looking at it. So I think that certainly if people come and all they do is laugh and walk away and all they've been is entertained, then I think we failed. I want them to feel like they've entertained, but also to feel like uh, maybe they feel a little unsettled, that the debate was lively, got them thinking, had them questioning their own approaches. So I think, and you know the speakers, you'll see that they're each one of them can be equally as entertaining as they can be educational. And so I'm hoping that that mix really hits it off so it allows the audience to get both the education component but also the entertainment.
It'll also be good if the audience has people with different levels of experience and they get up to the microphones afterward and really challenge the speakers and open up that discussion.
Yes, and we've purposefully in our planning spoke about limiting the length of time that each of the speakers will speak, because we want to allow a lot of time for discussion, because we want to stimulate people in the audience to come and say, well, you said this, but why? Or you stuck very firmly to that point, but why? So to understand the motivations behind that.
Well, I want to thank you, Dr. Street, for your time today and for joining us on the podcast. I don't want to preemptively tell you that this will be my favorite session at IMAST, but I'm definitely going to attend and I can't wait to see it.
Thank you. And on behalf of the Canadian Spine Society, we really appreciate the opportunity to be involved. And we hope that people will be more aware of our society and come to join us in the debate. We promise that you'll learn lots and you'll laugh lots. We promise that.
Definitely. So just as a reminder to our audience, IMAST is coming up soon. Join us April 15th to 17th in Toronto and mark your calendars to attend the Battle of Politeness, Canadian spine surgeons debating controversial topics on Thursday at 3:30 p.m. And this one is co-branded by the AANS and CNS. This session brings together a fantastic group of speakers to discuss emerging and sometimes controversial topics shaping the future of spine surgery. I'm joined by the session moderators, Dr. Daniel Sciubba and Dr. Luis Tumialan, to talk about what they're most excited about and what the audience can look forward to in this discussion. So welcome to both of you.
Thank you.
Thank you for having us.
Sure. This session is called Can't Miss, and it's going to cover a wide range of emerging ideas in spine surgery, from new technology to evolving surgical indications. When you guys were putting this program together, what themes or trends were you hoping to highlight for the audience?
Maybe I'll start real quick. When I think of SRS as the top shelf opportunity to really learn about scoliosis, its sister meeting, the IMAST, is always framed in technology. It's always framed in innovation. So it has the same scoliosis aspect and complex spine, but it's really that technology. So Dr. Tumialan and I really wanted to think about what is hot, what is coming out, what is controversial, what will make people come and put butts in the seats. And so that was the most exciting thing, is to think about what is exciting, what are questions that people are having, and then get really experienced speakers on that.
Yeah, Dan, I agree 100%. I mean, we're hearing a lot of chatter about a lot of this new technology, and reps will come and they'll talk to us. And we don't have a lot of that frame of reference. I mean, the 3D printed is one example where we do have a lot of opportunity in our own hospitals, but I'm not sure that I'd be that comfortable just doing that based off of a conversation I have with an industry representative. What I'd like to do is talk to someone like Praveen Mumanetti, who's going to be one of our speakers, and see what their thoughts are. And also, a lot of this new technology maybe has a great role. Maybe some of the old technology has a good role, and that's Charlie Sansur is going to be talking about. What are we using this new technology? Are you using it for every single thing, or are we using it in specialized scenarios where it's going to make a difference in that procedure, but maybe not for everything? And so a lot of experiences out there, and that's one of the best things of our professional society meetings is getting together and seeing, hey, what's new in your bag of tricks? What are you using? And we have all the speakers are going to be individuals who are by their inherent nature pushing the envelope. Paul Park talking about what you can do at an ambulatory surgery center. At what point is it too far, or is it normalized? I mean, before a 2-level ACDF would be controversial at a surgery center. Now we're routinely doing 3-level, and now with the changes in Medicare, the way they designate certain procedures, we can now do outpatient T-lifts. Now, I won't bat an eye at a 1-level T-lift outpatient, but am I going to do a 2-level? At this point, no. I don't think I'm there yet, or I'm not sure I've seen the right patient. But these are going to be all the topics that are going to be covered, and it's going to be the 3D printed surgery center, expanding the role for the surgery center, the newer technologies, all of these topics from individuals who are routinely using them in their practice.
It's definitely helpful to speak to someone who's already been through some of that learning curve and figure out how not to repeat those mistakes, for sure.
Yeah, Chris, just wanted to add on there to your point. A lot of us want to see great studies. All of us want to see great studies. We want to see peer-reviewed, generalizable data. The unfortunate thing about a lot of those studies is they're either small group of patients, maybe from a single institution, or they're a very strict inclusion criteria where we say, I don't know if that's my patient, because my patient's a little overweight or has a smoking history, or the bone isn't great. And what happens, I think, with these meetings is we have the interplay where once we have respected colleagues, which are always present at SRS and IMAST, and thank you for partnering with the Spine Section and AANS CNS, is that I get to say, what did that speaker say? And maybe pull them off the podium later and say, now, what would you do for my patient? And I think that's where we all learn best, is often I will say something to Dr. Tumialan, to Lou, and I'll say, Lou, what do you think about this? And he's like, I know that's in the literature. I never use that. I just don't feel comfortable. Or I'm pushing the envelope. No one's really published on it yet, but I'm doing this now. And those data come out before the papers are published, before the books are written. And when people are doing new things, we need our colleagues who are really experienced to say, it's safe, or it's worth the slide. The climb is worth the slide. And I think this is an opportunity with a number of these new technologies, which really haven't been published on a lot, to say, is this where the puck is going? So that's our goal with this.
I think it's also helpful that so many members of the SRS produce really quality work, and we can trust these people and their thoughts when we walk up to them afterward and say, hey, you are doing this. That's really interesting. I'd like to see if I can do the same thing. It's somebody you trust, that you respect.
Agreed.
That's an important point, because when you look at like Juan Uribe has a lot of currency in the lateral space, and to see Juan migrate, and I'm watching it in real time because he's one of my partners, to see him migrate to that prone lateral and applying the lessons learned from the lateral, and he was just, I never thought that I would see someone who, at that point in his career, who had mastered such mastery at the lateral approach, because I've had him come and help me with a handful of them, and to see him migrate to a different, it's a lateral approach, but it's prone, and he reinvents that from beginning to end, and the way he approaches that case. But just to see someone be part of it, watch them evolve, and then have that currency, because the fact that he's going to a prone lateral means there's got to be something to it, or else he wouldn't transition. Obviously, he's not using it for everything, but what are those times he's using it? What was the thought process behind it? And someone who had absolute mastery of one procedure was migrated to another. Mike Wang is another. Mike Wang was not formally trained in endoscopy. It was not part of his training. It's not a lot of any of our training. But spinal endoscopy is now having a unquestionable resurgence. I was on a conference call earlier today about the code and reimbursement component of it. And I complimented those individuals on the call, because I said it's because of your voices that has become germane again. Is because people are pushing the envelope with endoscopy, and Mike Wang's one of them. And he's another person that has been taught a bag of tricks and went outside of that to incorporate a new technology. And so it'll be remarkable to hear about the learning curves of learning a new trick later on in your career that Juan and Mike are going to be talking about at IMAST.
I'm sorry, just one last comment to jump in on there, since we really did name all the speakers and their topics. One thing is also all this sacroiliac fusion that we're doing now, which is really relevant. I don't know if it's as relevant, and you could probably comment on the pediatric more than we could, but definitely the adult deformity. Everyone, so many people are going down to the pelvis, and then if those screws loosen, what does that mean? And if we really do have a significant fusion across that joint, or at least into those screws, with 2 on each side with integrating screws, what does this mean? Does this lead to more PJK? Does this lead to more hip issues? It is really the premier meeting to have this discussion, because if you have it at a pain MIS meeting, we're talking about isolated fusions of the SI joint. And if we're having it at a DGen meeting, we're not really fusing the SI joint. We really have this as a deformity meeting because it has massive ramifications. And I really don't know where this is going to go. I could see in 5 years that everyone's being fused down to the bottom with tons of implants, or have we gone away from it with something else? And so another really interesting thing that would make the meeting exciting from this new innovation point of view.
I spent a month with Dave Pauly as a traveling fellow, so I've heard a lot about SI fusions in adults, and we're actually studying screw constructs, including 2 screws across the SI joint in kids, to see if that changes our outcomes. So I'll be paying attention to that one.
Great.
Now, looking at this lineup of topics, which presentation are each of you most excited to hear or discuss?
I think for me, as a neurosurgeon who didn't train at all in endoscopy, where you stick it's a 2D view. Even when we use the microscope in neurosurgery, it's 3-dimensional. And then even just looking at all the water and the bubbles and the things flapping, that is just so new to me. And now neurosurgeons and other surgeons are picking it up. I mean, obviously, orthopedic surgeons have experience in the joints. This is something that I've seen now presentations at least at our last spine section meeting just recently. They're taking out tumors with this. They're doing fusions with this. It is something that for me is new. I mean, I've been putting screws in the pelvis for, 15 years at least, and using some AI and doing laterals. But the endoscopy for me, I really want to see where we're going, and it's starting to get really exciting. And I don't know if it's going to just be a few people doing it, and they're going to be the the left-handed knuckleballers who we pull out of the bullpen. Or is this going to be something that every resident is going to train in, or every fellow who does spine fellowship is going to train in eventually? So I'm going to ask those questions of Mike, whether it's in person or after the session. But I think this is an opportunity for people who do complex surgery to say, is this part of your normal portfolio, or is this a super specialized, as I said, a knuckleball left-hander who has a very specialized thing. I don't know. And obviously, I'm looking forward to that.
Lou?
So when I look at all of the talks, I am doing elements of all of them with the exception of one, but nevertheless, that is the talk I'm most interested in, because anyone who takes trauma call takes care of a spinal cord injury patient. And I think of my last one, because here we are in March. I saw him recently. It was a tragic story of a Christmas Eve mountain biker over the handles, and now he has a complete injury at C4-5, not ventilator dependent. He can breathe, but he can't animate the arm. And he's a young man, 39 years old, and animation of that arm, just function, maybe to bring a cup to his mouth, a fork to his mouth, or operate his wheelchair better. And what our peripheral nerve colleagues are doing, because DSBN, which is the spine section, is the disorders of the spine and the peripheral nerves. We have a lot of neurosurgeons, a lot of orthopedic surgeons, and a lot of peripheral nerve surgeons who come to us through various disciplines are now animating the arm again in a spinal cord injured patient by selectively plugging in the harvested nerves into the functional elements of the brachial plexus. I think that is incredible. I think that's marvelous. And the impact that reanimation of an arm in a tragically injured individual, what that can do for their morale, for their independence, for just day-to-day things that we take for granted every day. And I'm looking forward to hearing what Zach Ray. He's our closer, and it's going to be how to reanimate the arm in spinal cord injury patients. So I think that's going to be the one that I'm looking forward to the most.
For surgeons who are attending this session, what do you hope that they walk away with? Do you think it's more of a change in how they think about a specific problem, or are you looking for something practical that they might actually implement in their practice?
Yeah, great question, Chris. I always say that to our residents and fellows and say, when you go to a meeting, don't try to boil the ocean. Maybe leave with 2 or 3 things. And I think you're nailing it. Like, what do you want them to leave with? And I think for me, it might be both, where you sit there and say, I want to leave with some inspiration. I want to leave with, wow, this is where, the flying cars are going to be. What the color of my flying car is it going to be? And where am I going to park it? That's the future. That maybe is the true animation where Lou's talking about. On the other hand, you also want to say, maybe I'll try this next week. Maybe I'll try this next month. Or maybe I'll talk to someone who does this week, and maybe go visit someone to see, like you were saying, Chris, and taking something from like a poly and incorporating it with pediatrics, which it makes a perfect sense to me since I don't do a lot of peds to the pelvis. That's something that I'm like, wow, that would totally be in your wheelhouse, such that anything you learned out there would obviously impact it immediately. So I think that maybe my advice would be, this is going to definitely be something with the spinal cord where patients have injuries. You're going to say, wow, where are we going to go? But maybe they're going to sit there starting doing prone laterals in a month or 2 because they know how to do laterals. And so I would say maybe 2 or 3 things from this meeting could go home, and just from this talk itself, from this session. But one maybe pie in the sky down the road, and maybe one next month. That would be how I would diversify my portfolio for these people entertaining our session.
Build on that. If there's something that we all glean from going to meetings, is that our soil is selectively fertile for ideas to land. These are they're all very new topics, but they're all disparate topics. We go from endoscopy to spinal cord injury to AI to pelvic instrumentation. So with all of that, all of the audience, we have no idea where they are or where they're listing in one direction or another. One talk may resonate with them, and that would be that several individuals can attend the same session, and everyone's going to leave with something that resonates most with them, which is where they are in their career. And that's the goal, is to cover enough of this new technology that you're reaching people at different phases in their journey to do what it is that we're doing in spine. If we think about it, we all kind of evolved into, you're doing pediatric spine. Dan is doing some of the most complex reconstructions of the pelvis and the sacrum with his treatments of chordoma. I'm an MIS guy who dabbles in trying to keep things getting smaller and smaller to see if I can match endoscopy. So talks are going to resonate with us differently if we even know we're in the same session. Same thing with the individual who attend to IMAST and come to this session, is that they're going to pick up a pearl here and there, and everyone will leave there probably with a different pearl. But as long as you leave there with a pearl, then it was a worthy endeavor to sit down and listen. And all of our speakers are going to give everyone a take-home point. And a great talk is something that if you can leave a session and say, I heard this, that's a good talk. If you can say something when you're getting on the plane about the IMAST session with that a talk was given, you can say, wow, that was a very good talk. But if you can say something a month from now or even a year from now about something you heard, that is the talk that just knocked it out of the park. And that's what we hope we can resonate with some of the individuals that attend this session.
I think you made two really good points I want to echo. One of them is that these debates really prompt a lot of discussion. And the other is that people are attending with all different levels of experience. And when you put those two things together, really great discussion and people of different levels of experience, it's just such a magical combination. And I think that's where people learn the best.
Yeah, I would add one more thing: is the speakers we've collected together here are extremely engaging speakers who are not. This is not Bueller from the old Ferris Bueller movie where all the people are falling asleep in class. These are some of the most engaging speakers that probably could make anything interesting. But if they're going to be engaging and the topic is relevant, I think everyone should really try to make this. I'm really excited about it, and I think it's going to be a good showing for us this year at IMAST, as we always hope to show.
All right, last question. I try to end with a fun one. So some of these topics are going to be a little controversial. And which debate do each of you think will generate the most discussion?
I personally think AI is pretty ripe for discussion because the discussion will go from anywhere from, can you use AI to help you write notes, to help you triage patients, to help you write research papers, to things like, are we not even introducing ourselves to patients? Do they have an autonomous intake person? Are they getting the history from them? Are the robots we use somehow AI guided? Are our instruments going to be constrained by AI constraints that don't allow us to go certain outside things? And so it could go very, very big, very quickly. And I also think it will be, and how can I say this nicely? It'll be a little embarrassing to some people in the audience. Not embarrassing. I'm going to use myself as an example where it's like, Dan, you're not doing this yet. Like, are you not with it, Dan? So I think it's going to be a little reckoning for some people. Like, wait, are you still writing with a feather quill? And are you still putting your saddle on your horse? There's going to be some provocative aspects of, hey, AI's here. You better get with it. And I think that's going to be fun.
Stone tablet all the way.
Exactly. Hammer and chisel.
All right, Lou, what do you think is going to be the most controversial?
Well, I mean, I don't think it ever, at what point does robotic instrumentation become the standard of care? Some people say navigation is, and then robotic, and then meaning that since I do this at an ambulatory surgery center, I must be some sort of prehistoric creature reading off of Edwin's papyrus. I'm using fluoroscopy. I'm using lower dose radiation fluoroscopy because I would suggest the standard of care is getting the pedicle screw into the pedicle. But I see the value. I mean, there's no question. I love some of these platforms to be able to plan screws, to plan the procedure. I think there's value in doing the procedure in our heads, but before, which is what you do with the planning software. But at what point does it? Do I no longer become relevant? And is it a vestige of my own insecurity that I'm not using the robot? Or navigation? Now, at times, there's a role for all of these things. But we've been hearing this clamor that this is rapidly becoming the standard of care for our trainees and and that you cannot do these procedures or should not do these procedures with two-dimensional fluoroscopy. Is that the case? I'm looking forward to, as a moderator, I'll be poking the skunk on that one. So, but I'm interested with that with that topic. It's something that we talk about in our own board certification societies. At what point is this going to be a standard of care in terms of safety? And is it the only way to achieve a high level of safety, or do we need to make sure that surgeons are not beholden to this technology, and that we need to train the next generation of surgeons to use all types of technology to include two-dimensional fluoroscopy? So that's going to be a very interesting topic to broach and to see what angle the speaker takes with that one.
There was a lot of controversy right there in your presentation of the topic, so that's going to be a good one. Well, Dr. Sciubba and Dr. Tumialan, thank you so much for this preview. It sounds like this really will be a can't miss session. And as a reminder to our audience, it's going to be on Friday at 1:15 p.m. at the 2026 IMAST meeting, which is April 15th to 17th in Toronto, Canada. So we'll see you all there. And thank you again, both very much.
Thank
Thank
you.
you for
It's been
having
great.
me.